Thank you so much, Miriana. Another terrific presentation. It's been fascinating to listen to the two of you and beautiful slides as well. We got lots of questions, so we'll launch straight into those. We've got about 20 minutes for questions. And I'm trying to organize. I'll answer the first question while I organize my slides. But the first one came out, I think, during your presentation, Catherine. And it asks, how does the exposure-based approach sit with the trauma-informed approach in terms of risk of re-traumatizing clients, aggravating trauma symptoms, and or deepening trauma neural pathways?
Yeah, I mean, that has often, for a long time really been the concern among clinicians is, are we going to do harm in doing this? Are we going to re-traumatize people by using these types of therapy? And the evidence just isn't there to support it. Having said that, it is vitally important that the people who are doing these types of therapies are trained in them and also receiving appropriate clinical supervision so that they are doing it in a way that is safe and is therapeutic and not re-traumatizing.
Thank you. And while we ask these questions, this is for the two of you. Please feel welcome to contribute. Um, um, sorry, I'm fighting with my screen here. Next question reads, what factors do you consider when beginning to address PTSD? For example, resourcing or how to ensure someone is within the window of tolerance?
You want to go for that one, Miriana, first?
That's fine. It's really, first of all, it will at the end depend on your client and their presentation. For me, first step is to help clients regulate and to keep them within the window of tolerance. And I think that would also mean that, once when we can and give them strategies to keep them within the window of tolerance, we can use exposure therapy or any other therapy. So I wouldn't, as a therapist, start with trauma processing if clients don't have skills to keep them safe within the window of tolerance. Resourcing is very important, but at the beginning of treatment, often clients are just not able to use resources that, and sometimes CBT and teaching clients on skills that they, at the beginning, if they are withdrawing from drugs and alcohol, if they are severely traumatized and can't pay attention, sometimes at the beginning we can't do it. But it's later on, it's very important, especially towards the end of the treatment, give clients resources. It's really develop their skills, help them develop skills to self-regulate. They will take this as skills for life.
Yeah, we found with our, as well, both in terms of the trauma symptoms and substance use, it's that working with where the person is at a particular time and what they want to do, what their goals are, what their priorities are. And by no means pushing something on them before they feel ready to do it, and being very clear and transparent about what it will involve and how they might feel and whether or not it is something that they would like to try doing. Having said that, I think initially a lot of the work, because of the concerns in relation to substance use and exposure-based techniques, a lot of the early work on these treatments was allowed a very long window of stabilization, but they would find that people would often drop out. And what they have started to do since, based on more and more safety evidence, is actually start to try and introduce some of the exposure work earlier, because it's thought to be, for this particular treatment, the elements that are going to make the most impact. So that if people are at a point where they're ready to start or willing to start, giving them the treatment that is going to make the most difference as soon as possible in their treatment. But again, only among therapists that are trained in using these particular techniques to put those into practice.
Thank you. I go to another question now. It reads, I have found some services will only address AOD and not support with mental health. So once off AOD, then they're not provided with support for what the AOD provided for them. Are you finding a change among AOD services to focus on PTSD as well?
This could be probably a question for you.
Sure. I think so. I think we are seeing a change. It's been, I think there's certainly a long way to go, I think, in both fields. I feel like the alcohol and other drug field has more recently kind of adopted the idea of taking trauma-informed approaches and are trying to upskill in being able to manage co-occurring mental health conditions more broadly. But also in working out how to work with mental health services in a coordinated fashion to provide the holistic care that Mariana was mentioning that a person will need. Having said that, I find often, unfortunately, that some mental health services as well, though, do tend to be still less inclined to try and work with alcohol and other drug clients, that they do at times, and I'm not saying this in a blaming way at all, it's just in terms of what people have been taught or known. This is where I work, this is what I can address, and I can't do that, so I'm going to put that over there. But there needs to be more of that communication between the services and working together, I think, on the issues. Not saying that any one person can fix everything or help somebody with everything that they present with.
Thank you. My throwing one address to Mariana now. Are there any specific tools that are used for assessing trauma and other comorbidities among refugees?
I'm not sure about drug and alcohol interview. There definitely should be some. For PTSD, yes. And we have tools that are specialized for assessing post-traumatic stress, assessing anxiety and depression in the refugee population. There are Hopkins trauma questionnaire. It's a Harvard trauma questionnaire and Hopkins checklist. They are available in different languages. And I'm not sure, Jorge, in how many languages we have them. And we have even computerized platform to use these assessment tools with our clients. So I don't know if we can advertise Multicasi.
Well, Multicasi is just a platform, but hopefully in about a year's time, we'll have a new tool that will be a bit more comprehensive and that we're working with centers, and the universities both in Australia, New Zealand, and Sweden and Denmark. So hopefully that will be available in about a year's time. Can I take you both to another really interesting question, which is actually it starts with, I find it interesting that one presentation recommends addressing SUDS first before doing trauma work, and the other presentation says this isn't the necessary order of treatment. Just to introduce some debate. Who'd like to go first?
I'm happy to go first.
Yep.
Yeah, I actually don't think we're that far apart or saying necessarily different things, because I should probably clarify that we certainly do focus more heavily on the beginning part about coping skills more broadly and about providing psychoeducation for people and normalizing of symptoms and really working out with them how their trauma and their substance use is fitting together and what alternatives can they put in place for when their symptoms perhaps may start to be exacerbated when they start to reduce their use. So I think both are kind of proposing to put forward a base of some coping skills that people can use before they go into this in-depth type therapy. And I totally agree with what Mariana was saying in terms of people can process and achieve more when they have been able to, cleanse their system essentially of what can interfere with that processing. And I think that's the optimal situation. I guess it's just that from our perspective and from the research, that it's not always possible. And for many people, they do find it too hard. So trying to figure out, well, what can we do to give them treatment to try and get them through, and maybe it's at a slower pace, but so that they are seeking improvements in both domains at the same time.
In our clinic, the reason why we decided to go first with the model Go and Detox and come for neurofeedback is because it's slowing down the process of treatment. It takes much longer, and in some cases, we were not really successful in helping clients. That doesn't mean that they don't have substance use problem anymore. They're detox. They are starting with the treatment. And then we jump in with neurofeedback that is actually then different tool to help them self-regulate. And that's why over time, they don't need anymore, first physiologically and then even psychologically, to go back to use their coping skills through use of drug and alcohol. But definitely we saw with some addictions, such as benzodiazepine dependency, we didn't have much progress with neurofeedback, tramadol use as well. And usually what we do in these cases, we need commitment. And commitment means you will have a psychiatrist. If you don't have, will work with you to titrate you from use of benzodiazepines. Is also very dangerous to just take someone off benzodiazepines. They can get seizures as a result. But we need that commitment, because then neurofeedback will have a place and it will help to re-regulate brain in a different way. So through our trial and error, we've seen that with some substances, we don't have such a progress, and we actually require as a commitment to start first with detoxing, but we are working alongside trauma treatment also to address problem with addiction. Because just being detox doesn't mean still that they won't have relapses. Doesn't mean that they don't crave drugs and alcohol. They do. And that's what we work with. We don't wait for all that to be resolved to start trauma treatment.
Thank you. Might take you to another facet of our work, which is that with young offenders who are drug users. What they're saying, when they get treatment institutions, but then they come back to their environments where they find the same context and begin to do the same thing again. So how do you work with that social aspect?
Do you want to go for that one, Mirjana?
With young offenders, I don't have much experience with young offenders. Definitely when I was talking in my presentation about working on spiritual dimension, working on strengthening their connections, it's very important that we address family and social issues as well, not just addiction and PTSD, because it's true. If they go to the same environment, there's chance that they will go back to their addictive behavior. But I don't have any experience with young offenders. I don't know, Catherine, if you do.
I mean, we've certainly had a number of people through our trials that have a history of incarceration or multiple incarcerations, and that's certainly their experience has been that they come out of those institutions and, I mean, they're not particularly rehabilitative in any way while they're there. So what's going to change when they come back out into the real world? And I think that does speak more to trying to advocate for those bridging sort of services, essentially those pathways out of incarceration and building on those foundations that are crucial for people to be able to start their lives again, employment, somewhere to live, those very basic things. But in addition to working on all of these other issues at some point that have contributed to where they are today.
Yeah, and it's not just about environment. Is they can change their environment and still go back to if that's the way how they were coping. They will go back regardless of where they live. So it's about developing their skills, resourcing them, working, and many of them, young offenders, actually are trauma survivors. So if they were not rehabilitated through working on their trauma-related problems and addiction, then they're going to the same environment, what you can expect in terms of outcomes.
We actually also tried because substance use disorders and PTSD are the two most prevalent mental health conditions among people who are incarcerated. So we had tried to do some pilot work in that area with male offenders, adults. And at that time, we did decide not to do exposure-based therapies, not to go anywhere near that at that time, because also some of the things that they're experiencing, those hypervigilance, the hyperarousal, they're protective when you're in prison. They do need to look out for danger. So we tried more those present focus therapies about how they could cope in the present with their experiences. They loved it, but it wasn't any different to just having a supportive counsellor there, but it was just having someone to listen that they found really beneficial.
The same would be for domestic violence and for children who are abused. You can't take those mechanisms that are actually protective for them. And that's why you are not going to attempt to do trauma therapy when someone is in an unsafe environment.
Thank you. There's another question which is addressed to Catherine, but actually, it's I think it touches on both your presentations. And it relates to exposure therapy. It comes from a member of the Yazidi community. And they recount that the annual program that is held there, where Yazidi seems to sometimes be re-traumatized, and that is followed by, many men drinking. And it suggested that the graphic pictures that show actual killings and torture of the fellows, the children and women, could basically bring nightmares and trauma to anyone. And it questions whether this is necessary. And I suppose it addresses the larger issue that we've dealt many times in the past in these discussions, is how can you use exposure therapy in a way that is appropriate and sensitive. And I think both of you
Catherine, if you want to go and
sure. Yeah, I mean, I totally agree in those kind of contexts. I mean, it's completely understandable to be having those responses. And I think I would just reiterate that the exposure therapy itself that's done therapeutically is done in a particular way in which it's not just a person emotionally processing the trauma, being able to distinguish between the past and the present, that they're no longer in danger. What happened was absolutely horrific in their lives, but now they are safe. And also processing some of the cognitions that they have around their thoughts about what happened, about their role in it, whether they have issues relating to blame, guilt, anything like that, and the way that they perceive themselves and others. And it's more through the process of the exposure therapy, the retelling of what happened to them and how they were feeling at the time, that is important. Many people can retell what has actually happened to them in a very matter-of-fact way, and be, but not actually emotionally process what has happened. The important part as well is often people have a lot of fear about doing it, but they often find that they actually cope better than they thought that they could when they do try to do it. And it's important that for the exposure therapy component to work, that people do sit with those uncomfortable and distressing emotions. If a person leaves that environment or seeks out for example, substance use to try and cope, they're essentially learning that they can't cope with it in any other way, and that it is highly anxiety provoking and they can't manage it. But through the exposure therapy, people generally tend to habituate to that anxiety and learn that it will not last. They can ride through it, and gradually over time, the peaks are lower and they're also further between each other. So it's never to say that the trauma itself isn't going to be distressing to them. It probably will continue to be distressing, but it's rather than having the trauma and their trauma-related symptoms controlling them and controlling their life, that they can still live the life that they want to live with what has happened to them.
And it's done gradually. So you're not going to expose someone to look at the photos of decapitated people. It's who wouldn't get traumatized and highly aroused. And that's not a space where you want to be to process and stay with traumatic material. You want to access that from a lower level arousal. That's why we use a lot of strategies to help initially reduce arousal through diaphragmatic breathing, through relaxation exercises, checking how it's going, having different way of how you are imagining and remembering what is happening, giving strategies of imagine this in black and white, if it's too threatening in color. So there's so many strategies that we can use to help our clients stay within that window of tolerance so that they can keep processing and staying with traumatic material without getting re-traumatized.
And I really love the promise of like everything that you were saying there, Mirjana, about the possibilities that more broadly of neurofeedback as an option to help people to be able to do these. It's amazing.
We're coming to the end of our session. I think you've got the record of questions. This is still, we've went through 8 questions. We got another 23 that we couldn't go to. I don't think we've ever got that many questions in one session. So I think that, it's tremendous interest, and I think it shows, how good the presentations were in eliciting this response. I'm just going to go through 2 very, very quick ones. We seem to have quite a couple of people asking whether the university runs these programs in Melbourne or are there similar programs that they can refer to in Melbourne, and also whether neurofeedback can be accessed in Melbourne. Of course, we do have a sister service in Melbourne, that's the Victorian Foundation, who provide excellent services for torture and trauma survivors. And one of our participants added that the Shattered Life second edition, that came out with, edited by Ida Kaplan, addresses some of the issues that we've been discussing. And certainly it's a very good book that I recommend reading. So Melbourne, are those programs, and Catherine, maybe if you go first, is it something similar to what the university is doing in Melbourne? And then Mirjana, whether it's neurofeedback.
There is at the moment a Turning Point Alcohol and Other Drug. It's both a clinic and a research centre, and they're currently looking at implementing these types of treatment. I think only in women, though, at the moment.
I know that there are private practitioners in Melbourne who are practicing neurofeedback and work with trauma, but also there is one service that is called McKillop Foundation, and they are using neurofeedback now in their work with children and young people who are in care of the States. So they are getting quite good results in helping those really the most vulnerable and the most affected by trauma young people.
Look, it's been a fantastic presentation. Thank you both so much. And thanks for the terrific audience and all the really good questions.